keep that screen up, BJ, the audience should be viewing that. And also, just a note to everyone watching: if this is our first live stream, so if you can't hear us, if you can't see the presentation, then please feel free to drop it in the chat box, which is a panel to the right-hand side. You should have access to a little question, little sort of message box you can open. But thank you for joining us today. As I say, this is a test run, sort to a degree. It's our first live stream. We are joined by Professor Singh, our orthopaedic upper limb lead. We've got a presentation of about 35-40 minutes for you, and then we will have a section at the minute, sorry, at the end for some Q&A. BJ, I think your screen has just dropped off. If you could just share it again.
Yeah, I'm just trying to see.
Bear with us, we'll be up and running shortly. Can you just share your screen again, BJ? There we go.
Yeah.
Right. I'll hand you over then to BJ. I'll be here the whole time, BJ, so the audience can hear you and I speak. And as I say, if any questions come in on the chat box to the right, then we read them out as and when they come in. But thank you. Feel free to start.
Thank you, Jamie, for the invite. And hello, everybody. Good afternoon. And it's a pleasure to be back doing some teaching. Now, as Jamie said, that this is a trial run on this live Microsoft Teams event. I have put some technology in this. I do hope it doesn't let me down, because otherwise we'll have to go a bit slow. So I'm going to kick off. There's a Q&A section which Jamie is going to monitor. And if you have any queries, please put it to Jamie. The housekeeping, there's no fire alarms today, so if it tests today, so if you hear one, you should run for the nearest shelter. What I'll also aim to do is, depending on the time, I will try and answer all the queries. If there are any more left, then please either email it to me or to Jamie, and I will get that answered. Now, this. I have to go out of full screen because there's no movement on this.
Yeah, if you, I'd recommend don't go into full screen, BJ. If we stick on the one that you were on, it won't. I don't think it will pull through. Yeah.
Okay, so there's no conflict of interest related to the talk, except to say that my wife's a GP. She may be listening in. I don't know. So what I'm aiming to do is to talk briefly about the MSK conditions that I deal with. Mainly talk about steroids and how I've managed and what the current guidance is in the current COVID pandemic and what I've done and achieved so far. Can you still see? I think there's quite a bit of lag, Jamie. Is that right?
No, I can still see fine. So I can see your presentation, and the audience should be seeing that as well and hearing us over the top.
And is that in sync with the slides?
Yeah, it will be. There's a delay of about 10 to 20 seconds for the audience, but
okay.
For us it should be.
Okay, that's fine. Yeah. Okay, that's good. So yeah, so steroids, the side effects. Talk about specifics about certain injections, and also touch on the alternative that is there. Now, we know pain, especially back pain and neck pain, and osteoarthritic pain, is the most common limiting long-term condition in the UK. And about a third of people live with this disability throughout. Roughly around 7.5 million days is lost due to pain of various joints across the country. And about a fifth of the nearly 300 million consultations that are undertaken by GPs and in the primary care, a fifth of them is for musculoskeletal disease. And if we can help it and train the primary care physicians, then that would be a great help. Now, these are two boxes where the top 10 conditions, the left one is from UK and the right one is from the US. You can say the MSK condition comes fairly right at the top of why patients see a GP. Now, steroid injections is not something new that I'm going to talk about. I mean, it's been used in the MSK musculoskeletal treatments for years. It helps by easing the pain, increases the mobility, and also provides a better quality of life. Now, patients often ask me whether this is a cure. And the answer to that is not a cure. What I'm aiming to do is to provide them enough pain relief that in certain conditions, yes, it will cure the condition, but in vast majority of them, it will make the condition more manageable. So what is the evidence? Injectable steroids have been around for over 50 years. Fortunately, there are not many studies where people have looked at the efficacy like with other treatment modalities because we know it works. And equally less amount of studies comparing the injections, steroid injections, and other injections for other modalities. Most of expert opinion, and it may lack some consensus. The challenge often is to apply the best possible events that is available in the current situation. Now, as you are all aware, when the pandemic started in sort of late February, early March, there was a big concern about use of any steroids in any treatment of anything, leave alone MSK injections, which was quite a lot bottom of the pile. And the reason for that was there were concerns because of increased mortality with the MERS and the SARS infection initially. Although the studies from SARS showed that there was no evidence that steroids cause harm, the caution was put in quite significant to use of any steroids in patients who needed them. And this is a concern. So if you look at triamcinolone, which is the Kenalog in trade name, 40 milligram, which is what a standard articular or periarticular in a large joint would be, is equivalent to 10 times the normal daily physiological steroid production. Injected steroids have shown various degrees of adrenal suppression, and we do not know the exact impact of what this does. However, there is an increased risk of adverse outcome from any infection, especially in the vulnerable groups, which is the over 70s, the diabetics, patients with ischemic heart disease, chronic lung conditions. And so those were the ones where there was some concern. Now, once I was doing this study, I looked at the literature, and I'll just quote two papers really so that I don't bore you with lots of data. Is that this is Friedley et al. Who published a large study, and they reported that only 1 in 150 suffered an adverse outcome event that could potentially be related to immunosuppression, despite the relative high steroid dose being used. And this is parenteral use rather than in an articular form or an oral route, rather than an articular or a musculoskeletal one where the absorption is much less. Looking at another study, Yusuf et al. Looked at the risk, infection risk and safety of corticosteroids in patients with rheumatic conditions. condition, and they found there was no significant increased risk in corticosteroid arms of moxifloxacin. Now, unfortunately, this slide doesn't show up as I would have liked to, so bear with me. So what this, another large study looking at nearly 100,000 patients, and they showed that the risk was probably 1 in 1,000 of infection or any adverse reaction, and they calculated the mean dose equivalent of methylprednisolone administered with each corticosteroid injection was about 1.5 times, and it was significantly lower in the upper limb cases. And also, if you look at the guidelines, so none of the Pain Society or the Rheumatology Society or the British Orthopaedic Association have ever said that there's an embargo of using corticosteroid injection. But a lot of practitioners, including my colleagues, have taken the view that it should not be used. So what was the guidance that was issued? Now, the British Orthopaedic Association, the Pain Society, and the Rheumatological Society, they produced this document. This was in the early stages in March. They said, do not stop existing steroids, but taper dose if possible. Think before starting steroids in the current epidemic. Use low possible dose of steroids and only give steroids if significant disease activity and there is no alternative. And this was at a time when we did not know much about the disease itself. Further on, this is more recent, they have said that there is nothing new here. This is what you and I would do even in the non-pandemic situation, where you would screen patients for any signs and symptoms that may indicate presence of infection, especially respiratory infection, and in this case, COVID. And the clinician must use their judgment to make it on an individual basis and consider injection if this is going to help, which is what we would always do, and always discuss and assess the other options that is available. The only difference is that in this situation, in current situation, it is more relevant to do so. Now, this is the latest guidelines produced for musculoskeletal upper limb from the BOA, the Hand Society, and the Shoulder and Elbow Society. And they said that the body's immune system may be temporarily affected, which is present. And if you've got a patient who is immunocompromised, then caution needs to be even more. And it shows that the risk of catching flu following a seasonal winter flu period is pretty low. And what the steroid does, it does is to reduce some of the ability to fight against infection. So there is no embargo against using it. But before we start to inject patients, what I would suggest is to look at different bits and pieces. So the first thing is to look at the type of steroids. There's a short-acting steroid, which is your hydrocortisone, your intermediate-acting steroid, which is the triamcinolone or Canalog, and methylprednisolone, which is the depomedrone. And the long-acting is your dexamethasone.
Everything okay, BJ?
Yeah. Now I'm just gone into trying the full screen again to see if it's going to work.
I'd be hesitant to use it. It doesn't seem to pull through to the
Okay.
production area.
So, and then the other thing is to look at is the solubility of the steroid that you're going to use, whether it's an insoluble, so your triamcinolone acetonide, which is a Canalog, or the slightly soluble one, which is the methylprednisolone. which is the depomedrone. The dexamethasone is not something that is commonly used or advised to be used for any musculoskeletal problems. Be aware of the systemic side effects, which is generally very uncommon. Facial flushing, glycemic control. Yeah, so this is one thing I always warn patients about, is the glycemic control. If they're insulin controlled diabetic, I always warn them that for about 48 to 72 hours there, the diabetes control will be a bit off, so they may need to monitor that. The rest of the is something that you don't see frequently in clinic. The local side effects are, however, more common. So I always warn patients about post-injection flare, certainly in the first 24 to 48 hours. And I always advise patients to avoid anything heavy for that period of time. And then they do whatever they want to resume their normal activity. Now, skin depigmentation and atrophy is more common. This is more common in superficial areas, so if you're doing hand injections. Patients with dark skin color, like myself, have a higher risk, but it can happen, and I've seen it in Caucasian as well. It's a different kind of white, as I call it. And it's related to soft tissue atrophy and fatty atrophy, causing local depigmentation. Although the books and the literature says that it improves over 6 months to 2 years, I don't think that changes that much, and a sensitive patient may not want it. So I always advise patients again about it. The other local side effects are uncommon, so bleeding, bruising, tendon ruptures, infection, and steroid arthropathy. One of the questions is whether you inject if patient is on any blood thinners. And I haven't required to have not seen any side effects or any increased bleeding because of the injecting patients who are on blood thinners. But that's one of the things that you need to be cautious. I think more important is when patient has got a bleeding disorder and that is a bit uncontrolled. So in those situations, I would advise to speak to the hematologist before that. If patient has got a prosthetic replacement, especially if it is around where you are injecting, then maybe worth considering a discussion with the patient and the surgeon. But say, for example, if a patient has got a knee or a hip replacement and comes for a carpal tunnel injection, I don't think that's required. And most important is the patient's previous response to the injection. Now, the contraindications are obvious. If there's an infection within the joint or a skin infection, and there is allergy to any of the medication. One important thing that I've been telling is if a patient is needing surgery, then what is the time frame that one requires in between the injection and the surgery? I always use local anesthetic when I do my steroid injection. So this helps in 2 ways. One is it allows the diagnostic confirmation that the injection has gone in the right place. And it also makes that patient less painful when he or she finishes in your consulting room, although they might get a bit of flare-up afterwards. The dilution gives you a larger volume so that it's got a better chance of spreading, and the distension volume effect may be useful in certain conditions. So the types of injection you can do is an intra-articular or a periarticular, a bursal, intramuscular, and a peritendinous injection. Important thing about the good injection therapy is to place the appropriate amount of the drug at the appropriate time into the exact site of the affected tissue. Now, joint injections, it would be good to see some plain radiographs unless it's a soft tissue condition. Image control, yes, the world is moving towards that direction, but I still think that sort of these injections can be done with Mark 1 eyeball, and there is a learning curve to it. Soft tissue injections is easy, especially in primary care, because it's a common condition, easy landmark. There is a large area to infiltrate, and there is no specific equipment that is required. Now, if we look at the shoulder, so the source of pain in the shoulder can be from various sides. You can have the ACJ pain, rotator cuff tendinopathy, or a tear type of pain, biceps problems pain, glenohumeral joint pain, as well as referred pain from the neck. And the common conditions that we see, except for instability, any of these can cause shoulder pain. Let me give you a few scenarios. So in a 30 to 50-year-old, which is a very young age group, generally active patients, the probable diagnosis is tendinopathy, arthropathy, biceps problem, or slap lesion. Glenohumeral joint OA is less likely, a frozen shoulder, or a cuff tear. I think, except for patients who have traumatic shoulder pain or any red flag signs, I'm happy for these to be injected. Scenario 2, 50 to 70-year-old, again, more common is cuff tear, impingement, osteoarthritis. And as the age increases, cuff tear arthropathy. And again, even in these cases, unless it's a traumatic situation, you can, my first line of treatment would still be an injection of a steroid. And scenario 3, where slightly older age group patients with more degenerative conditions. So even in those, even if they are traumatic, in these cases, you would be safe to inject. So in short, what I'm trying to say is that steroid can be used in any age group with some exception as the first line of treatment.
We've had a question come in.
Yeah.
So Gareth has asked, do you vary the lidocaine volume dependent on body size, firstly?
No, so it depends on the joint and the area to be injected.
Okay. And secondly, have you had experience of injecting one of two painful limbs and subsequently getting relief of both problems?
Sorry, come again on that, Jamie, please.
So if you have two painful areas of pain, two sites, have you injected one and relieved both pain in both sites? So
yes, there is always a secondary effect in any of the joint or musculoskeletal pain that a patient has. Obviously, where you inject it locally will have the bulk of the effect, but as the steroid is absorbed in the circulation, the patient should expect some improvement generally, yes.
Sure, thank you.
Now, this is where the technology is a bit not kind. This should have been a nice demonstration of my technical IT skills as well. But hopefully, what you can see is that you can inject the shoulder from the posterior side, the lateral side, or the anterior side, and they are all color-coded. I generally prefer to go either posterior, or if I'm using an ultrasound, then I go lateral. Try and avoid anterior, and I'll explain why. Clinical reasoning, and also the more logical reason that you don't want to punch in your face. So the reason for going posterior is, I'm sure you all remember from the anatomy teaching, is that the acromion can be of a flat, a curved, or a hook shape, and the distance that is present anteriorly decreases as the shape changes from a flat to a curved to a hook shape, while at the posterior end, from the posterior approach, that gap is constant, and the landmark is about 2 centimeters proximal and medial from the edge of the acromion. And laterally, what you would also see is that if a patient has got cuspal arthropathy, then the gap will be a bit less in the acromiohumeral space. But again, the bursa does come fairly low down, if you remember from the first X-ray. So you will catch that bursa even in that case. This is doing a short video on the anatomy of the shoulder. So that's the anterior edge, and this is where you would go from the front and looking at the posterior aspect. So you can see that's the posterior acromion, and you go about 2 centimeters below and medial. And from that point, you can either go into the subacromial space along there anywhere, or if you change the tack, then you can go into the glenohumeral joint as well from the same spot. Actually, you can inject in any of that plane where the bursa is present. Now, coming around anteriorly, as I said, apart from the not being punched in the face, as you can see, as this gap decreases, and also the presence of the coracoid, the long head of biceps in there, the space becomes quite crowded. So this is on a live patient. I'm palpating the posterior lateral aspect of the acromion, about a centimeter or a finger breadth below. If you've got fat finger like me, that's about a centimeter and a half, distal and medial. And laterally, you can go anywhere along, and in the front, palpating for that. So posteriorly, this is to show where to go from that point. And if you drop your hand, end up in the subacromial space. If you go medially, that will go into the joint. Laterally, you can go anywhere along just under the acromial space. Anteriorly, the landmarks are a bit more tricky and a bit more muscular to go through that space. Moving on to the elbow, this is a pretty straightforward. The conditions that you see here would be your epicondylitis or epicondylopathy, the tennis elbow and the golfer's elbow, ulnar nerve problems, and osteoarthritis. Now, injecting the elbow, the common one would be around the tennis elbow. And here is what has changed in the last 4 years, 5 years, is movement away from steroid to using PRP injection, but still there is some room for using the steroid injection in patients who've got severe pain. And injecting the elbow joint per se is, I'll show you this video, wherein you palpate for the lateral condyle and then go about 2.5 centimeters distal to the lateral condyle. And then as you supinate and pronate the forearm, you will feel the radial head, and then you will feel a soft spot in between these two landmarks where you can inject into the elbow joint. For the tennis elbow itself, I go onto the condyle and I use maybe 4 or 5 times punctures and inject a small volume. In the wrist and the hand, the common conditions are your carpal tunnel, trigger finger, thumb base, arthritis, DIP and PIP joint OA, and decurrent sinusitis, which would need injection. For the carpal tunnel, it's quite straightforward. You get the patient to lift the thumb up, which will demonstrate your humerus longus. And generally, if you go in that area, I do not go into the carpal tunnel itself. But if you inject just proximal to the wrist crease, the capillary action will take the injection into the carpal tunnel. Thumb base arthritis, again, fairly common, and this sometimes can be a bit difficult to do an intra-articular. So here you can do a periarticular injection, and I will show on a video in a second. This is a trigger finger. Now, as you know, this, because of the nodule that is seen, I'm not going to bore you with the. And you can see this patient has got classic So that can be quite safely injected. Decurve and sinusitis. So again, testing is important, as it's not the pressure onto the anatomical snuff box, because if you press hard enough, you will get pain because of the superficial radial nerve. Is the Finkelstein test by just pushing onto the thumb into the palm should cause pain. This is a video incorporating all the sites of injection. So first to begin with is the thumb base. I feel for it, and if you give a gentle pull, should be able to feel a bit of gap between the metacarpal and the trapezium, and you can get into the joint. Even if you get periarticular, that should still work. For the decurve and sinusitis, you just get a bit proximal to that and along that area. And again, even here, I do not attempt to go into the tendency, just around the tendency. For the carpal tunnel, this is where I'm asking the patient to lift up the thumb to show the palmar is longest and to inject around that area. Now, just to finish off, just to say what my experience has been in the COVID pandemic, I've probably done nearly 100 injections in the last 4 or 5 months. This is a survey that I carried out for patients, and about 60 patients so far. And you can see there were full age group, different age groups, nearly half were over the age of 60, equal distribution in the sex, male and female. And about half of them, just under half of them, had some chronic underlying conditions. Following the injection, this survey was asked within the 14 days. These questions are based on the government website, NHS, whether they had any cough or any shortness of breath, any sore throat, or any temperature. And except for one patient who had some shortness of breath unrelated, none of the patients demonstrated any signs. About half of the patients were tested for COVID and they were all negative, and half of them did not need a test. And nearly 50% of patients did have some concerns about having a steroid injection before they came to me, and they were happy with the symptom relief in the vast majority. Of course, some of them don't respond, so they are going to be not too delighted with the outcome of the injection, but they did not have any issues following that. The site of injection, joint problem and tendon problem, most common. And following on from me, the lower limbs, so the foot and ankle and the hip and knee surgeons have also started. And you can see this is reflected now into the survey. What are the other options? As I said, we've got the PRP injection and hyaluronic acid. Certain conditions like the tennis elbow can use shockwave therapy. PRP injection, this is now available at KIMS as an outpatient. There are different companies that market this. This is the one that I use, where the patient has his blood taken about 15 mils. Now, this particular device gives about 2 mils, 1.5 to 2 milliliters of plasma for every 5 milliliters of the blood. So depending on where one is going to inject, decide what volume of platelets, PRP you need and how much blood you need to withdraw. So this is for a shoulder injection. So I'm drawing about 15 milliliters of the blood. This is then put in a centrifuge according to the company's direction. Generally takes about 4 to 5 minutes. There are various types of PRP that is available, and maybe we can have a discussion at some of the this system, the syringe comes out, and it's a pretty straightforward system where the plunger is inserted, 3 syringe system, and you will see the plasma rise into the middle syringe. And you can take as little or as much of plasma that is generated as much as you want. You can see there, that's the plasma. You twist the syringe, and that's the plasma. You can see there's just a tinge of blood that has come into that. It is not a big problem if there is a little bit in that.
So BJ, is the PRP offered in any of the NHS clinics at KIMS or via?
So for NHS patients, I would need to do that in theatre. That's the arrangement that is there. So for NHS patients, I would do it in theatres, but yes, it is. I am offering for NHS patients as well. It's not practical to do NHS patients in clinic.
Okay.
And then this patient had the biceps problem, so I'm injecting his biceps under ultrasound guidance. I have this portable ultrasound. It shows quite good quality picture on an iPhone. And you can see that's the needle coming in there, and that's the bicipital groove. And then from the same portal, I can twist it, pull the needle out, and then go back in again to see where the needle is coming, and then inject the subacromial space. I think the key is that you need to stick to the guidance that has been provided, use PPE as required. I think in the current situation, although it's safe to use steroids, if you can reduce the dose, that will be helpful. And the PRP, where can it be used? Tendinopathy, tennis elbow is probably the commonest where I've used. I'm also starting to use in rotator cuff tendinopathy, thumb-based arthritis, and early osteoarthritic shoulders, where I've undertaken an arthroscopic debridement. And there are some promising results, although NICE has not yet completely confirmed it. So where can this injection be done safely in primary care? I think it's safely done in subacromial injections, the ACJ injection, tennis elbow, carpal tunnel, trigger finger, and thumb-based arthritis, and with a bit more practice, glenohumeral joint injection as well as elbow joint can be performed safely. So I think in summary, steroid injections have a great role to play in the MSK. Please use it judiciously to help patients. I certainly haven't seen any increased risk in COVID. And just if anybody else is interested, the Oxford Group are doing a nationwide multi-center trial as well for the same. Otherwise, follow guidelines and advise patients. The one thing that I have changed slightly in the last 3, maybe 6 months is I have started formally consenting patients, even in outpatients, before doing the injection. And I do have a leaflet for steroid injection, which I give to the patient before they have any. So thank you very much, Jamie. That's my talk done. Be happy to take any questions.
Sure. There is one outstanding. I'm probably going to butcher the pronunciation of this, but in the absence of palmaris longus, how do you direct your injection? So
yeah, so I knew that was going to be asked. So if the palmaris longus is absent, the palmaris longus is in 10% patients, not patients, 10% of population, palmaris longus is absent. So in that situation, you would go in the middle of the wrist joint, just proximal to the wrist crease, and inject. Now, the key to remember is that if you are very close to the nerve, the patient will get tingling and sharp symptoms. So you should stop and withdraw your needle and then re-enter next to that
And we just have another. How many injections can one patient have per joint, especially if they're considering surgery?
Okay, so now that is a very a question that is asked very commonly as to how many injections can I have. So it depends on multiple things. Most importantly, the patient, the age, and what conditions the patient have got, and what has the response been to the previous injection. So, for example, if I see let's say, and this is what I always tell, if I see an 80-year-old patient who's got a shoulder cuff tear arthropathy, not medically great, doesn't want surgery, then in those situations, I would be happy to inject them every 6 months for the rest of their life. Equally, if the same 80-year-old was fit and well and wanted the quality of pain control, and I know that doing a shoulder replacement would give them that, then I would discuss that. So I think at the end of the day, it's a discussion between patient and the clinician. And so the other myth is that you can only have 3 injections. Some people say in a year, in a lifetime. There's nothing like that. There's no literature, any evidence to say that you can only have 3 injections. The question about surgery, now there is evidence coming that if your patient is going to have a soft tissue surgery, for example, a rotator cuff repair, then perhaps the 3 months window is showing that they have a greater risk of repair. And in arthroplasty, it's between 3 and 6 months is what is recommended to avoid if possible.
Am I right in thinking that often patients can be given steroid sort of for prehab purposes, so they can actually strengthen the muscles and strengthen the joint prior to surgery?
So yeah, I mean, if you look at the rotator cuff impingement or tendinopathy kind of problem, in those situations, the role of the injection is to improve the pain, and also, and that way they can then go on to the strengthening exercises, which sometimes patients can't do because they're in so much pain.
And what are your thoughts on providing injections to over 80s who are due to have the COVID vaccine?
That was a question that I actually also heard this morning. So I think because it's a live attenuated vaccine, it should make no difference than having if you were going to have a flu vaccine. So it's an mRNA, so there is no live virus in there, so that is pretty safe. But except for the fact that patient might feel miserable for a day or so following the vaccine.
Sure. And how safe is it to inject subacromial bursa without ultrasound guidance?
It is very safe to inject subacromial space without. That is probably one of the safest ones to do because the size of the bursa is so big that you're less likely to miss any side.
Okay. So when using a local anaesthetic, do you wait for it to take effect? And if you don't wait, why do you give the local? Is it for diagnostic purposes or because it makes the patient feel like the injection will work as immediate pain relief?
So I put the local anaesthetic, I didn't make it clear, I do put the local anaesthetic mixed with the steroid. It's not 2 injections. And the reason for mixing the 2 together is, as I said, if the local anaesthetic will provide almost immediate pain relief.
Sure. Do you do hip injection landmark or ultrasound guided?
For hips?
Yeah.
No, I don't do hip injections. So for hip, if you're doing I would say if you're going to inject a trochanteric bursa, then you're probably safe to do that with Mark 1 eyeballs. But for the joint injection, you either best using an ultrasound guidance or a fluoroscopy guidance, probably with a radiopaque dye.
Sure. Is there any guidance on the minimal interval before injecting the same joint?
There isn't anything written down anywhere, but if the patient hasn't responded to one injection, say even for 6 weeks or so, the only time I would consider doing that injection if they were planning to postpone their surgery by a few weeks after the second lot of injection.
Okay, sure.
So if the patient hasn't responded, then you've got to start thinking either they are not going to respond to that, or B, you even have to start thinking whether your diagnosis is right.
Okay, I think that's about it. Thank you for joining us, everyone. Because this is a test, so Microsoft Teams has said we will get a list of attendees, and obviously we can then use that to send you out your certificates along with BJ's slides. If you don't hear from us via Friday this week, could you assume that we haven't managed to get that list from Teams, and just drop your name to education@kims.org.uk, and we'll be sure to get the slides and the certificate out to you. Welcome your feedback as well. I appreciate it may have been a bit stop-start, however, it is our first. Thank you very much to Prof for joining us. And any further questions, you're very welcome to send to education@kims.org.uk. Thank you.
Thank you, everyone.